Good afternoon, everyone. My name is Dominic Akateba. I work with Ghana Medical Health. Thank you so much for joining us this afternoon in Ghana and morning elsewhere for our Canadian team for this webinar on chronic hepatitis B. This is a common medical disease that we encounter in practice, especially here in Ghana, Ghana being an endemic country for hepatitis B, according to the WHO. The scenario is even worse of when you move from southern part of Ghana to the northern part of Ghana, where virtually every other patient that you will see on admission with a gastrointestinal issue is related to chronic hepatitis B. So it's important that we join this webinar, and we are happy to have you. There's no better person than Dr. Abednego Atto, who is a physician specialist, freshly minted, and with us at the Upper West Regional Hospital. He's a legend for those who know him. I'm sure I will learn a lot as well, and I'm sure lots of you on the call today would do same. Kindly take note to keep your microphones muted. I'm just putting up that setting wherein you'll be unable to unmute yourself until the end of the webinar, and then we'll allow you to be able to unmute, and then we'll have a discussion. So guys, kindly join me in welcoming Dr. Atto. Dr. Atto, our participants are waiting for you. Please take over. Thank you.
Thank you very much, Dr. Akatiba, and I'm very happy to be here to make this presentation. I think the last time I made a presentation here was, I think, in 2021, thereabout. So it's been a while. And if I can be heard loudly, then I'll just proceed with the presentation.
Great, you're loud and clear.
All right, so today we'll be looking at, and thank you all for joining, and today we'll be looking at chronic hepatitis B. And just like my boss, Dr. Akatiba, said, it's something that is very common, and especially here in the North, we see it almost on a daily basis, and we have a lot of patients coming in with either the acute form or the chronic form with the various complications that they come with. So what I will try to do in this presentation is to, first and foremost, try and define what chronic hepatitis B is, then who and when to treat. We'll look at the targets or endpoints for treatment. Then we'll evaluate chronic Hep B in special populations. So that will be my main aim for this presentation. And I hope that by the end of the presentation, at least we will leave here having known what a chronic Hep B is and who are the patients that qualify for treatment. As we all know, not all the cases of chronic hepatitis B that we get will require treatment. So it's important to know which of them qualify for treatment. Presentation will take the following outline. First, we'll look at the epidemiology, virology of hepatitis B itself and why it's so difficult to completely cure it, various pathogenesis and risk factors, and also modes of transmission. We'll look at the phases of chronicity, the natural history of the virus, and how to interpret the serology that I've realized that still most of us struggle to interpret. We'll look at the clinical presentation, then we'll look at the current guidelines. The most recent guideline we have for hepatitis B is the WHO 2024 guidelines, which was published in March last year. And I realized quite a number of people are still not familiar with that. And we'll look at the targets for treatments, then we evaluate treatment in special populations like pregnant women, people with retroviral infection, co-infections, and others. We'll look at the complications, then we'll conclude. And before then, I just want us to quickly go through the case. We don't have to make any attempt at answering it yet, but I just want us to go right. Then if there is time after the presentation, we'll quickly come back to the case. And these are real life cases. I just selected 4 of the cases I've seen here since I've been here, and I want us to just have a look at it. So the first case, a 35-year-old who came to the ER with nausea, vomiting, and lethargy. And past history was significant for type 2 diabetes with poorly controlled sugars. Patient was also known to have chronic hepatitis B. Other findings were unremarkable. Clinical exam revealed an acutely ill woman who was jaundiced with moderate pallor. LFTs done were unremarkable, but ultrasound showed chronic liver parenchymal disease, and the APRI score was 1.8. Ritual screen and hepatitis C was not reactive, and later on we'll get to know what the APRI score is. I just want you to think about these cases. Would you treat this patient or not? In the case two, a 28-year-old woman I was called to see, 34 weeks pregnant. We were called to see on account of her B surface antigen positivity. The profile showed no antibodies to the E antigen, but she had core antibodies and also no surface antibodies. LFTs, ALT was 67, AST was 55. Other parameters were unremarkable. Ultrasound was not done. Viral load was requested, but couldn't afford. In such a patient, would you treat or not treat? The third case is a 45-year-old who was referred to see the physician specialist, diagnosed of hepatitis B 8 years ago and was lost to follow-up. Known to abuse alcohol, usually drinks to stupor, was started on tenofovir disoproxil fumarate 300 milligrams daily a week prior to his visit to us. Examination findings revealed a severely cachectic man who was more moderately pale, had a tinge of jaundice. He had hepatomegaly, which was about 12 cm below the right costal margin with moderate ascites. Sensorium was intact. Alpha fetoprotein was 17. Ultrasound showed features suggestive of hepatocellular carcinoma. LFTs were deranged. Would you continue his treatment or not? Remember, this is a patient who had been started on tenofovir about a week before they came to see us. In the last case, a 32-year-old male who was referred on account of surface antigen positivity for hepatitis B, and we're seeing him at the clinic for the first time, no complaints, no family history of hepatocellular carcinoma or any GI malignancy, no comorbidities. APRI score was 0.3. Ultrasound findings were unremarkable. LFT, ALT was 33, viral load was 200 international units per mil. And that is the displayed Hep B profile status. Surface antigen was positive, and the antibodies to the E antigens and the core antibodies to the E and CN and the core antigens were all positive. In such a patient, would you treat or not treat? And if you present 6 months later with an ALT of 45, would it change anything? I selected these cases, and these are real life cases, just to highlight the various forms in which you can have patients with chronic hepatitis B presenting. And when we are done and there's time, we will try and answer the question, and that would reinforce whatever I would have learned here today. All right, so before I start, I think we just need to look at some of the definitions I'll be using so that it's quite clear to all of us what we mean when we use certain terms. So basically, I'm not going to go through all of it, but you would hear me mention things like inactive carrier state, resolved hepatitis B, reactivation, E antigen clearance, and E antigen seroconversion. Basically, when you say you have chronic hepatitis B, it means that there's persistence of your surface antigen for 6 months or more. Basically, that's what it means. And for those that we describe as being in the inactive carrier state, they have the persistence of their surface antigen, but without any significant ongoing necroinflammatory disease. And if you attempt to have resolved hepatitis B, then it means that you previously had the infection and there are no further virological, biochemical, or histological evidence of an active infection. So basically, this is what it means. And for those that we describe as having E antigen clearance, it means that previously they had the E antigen and now they lost it. And when we say E antigen seroconversion, it means they develop the antibodies to the E antigen. We all know that hepatitis is still a major public health burden in Ghana, and it's still so huge. And we know the virus itself is very, 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 very smart. It's highly infectious, even more infectious than the HIV virus. It's believed that it's about 50 to 100 times more infectious than HIV and about 10 times more infectious than hepatitis C. And I want to believe that out of all the hepatitis viruses, Hep B is actually the most infectious. It's caused epidemics in parts of Asia and Africa, and about a third of the world population were affected at some point. And the estimated number now is currently about 350 million people who are living with chronic, who are actually living with hepatitis B, and we term them as having being chronic carriers. And the most important, of course, complication that we know of is the development of cirrhosis and hepatocellular carcinoma, which we'll look at in subsequent slides. So this is just to highlight how important this is to us, because if you look at the map of the areas with high seroprevalence, Ghana is somewhere here in West Africa, and you see the whole place is red. What this means is that the estimated seroprevalence is more than 8%. And if you live in an environment where the estimated seroprevalence is more than 8%, it means that you are at a high risk. Your lifetime risk of infection is more than 60%. So just by the fact that you were born in Ghana, your risk of getting hepatitis B is 6 out of 10. And that is very serious. And people are enjoying because they are here yellow. Yellow means their seroprevalence rate is less than 2%. So we are in a highly endemic country. So it's important that we educate ourselves and we learn about hepatitis B so that we can take steps to prevent any future infection. And this map just reiterates what I've said earlier. And you see, this is actually the map of Africa and Ghana. We are somewhere here. And you see the whole of almost the entire Africa is red. That means that we are highly endemic region. And if you have about 60% of getting hepatitis B from whatever source once you are born here, and the burden is still so high that I cannot overemphasize how serious it is for us to take steps to mitigate the transmission and spread of hepatitis B. And this just once again reiterates the point I've made earlier. You see the carrier rates in sub-Saharan Africa, of which West Africa is part, is more than 8%. So we are highly endemic. And this also tells us the predominant mode of infection, especially in areas of high endemicity, is mainly from mother to child, or what we call the vertical transmission. Whereas if you look at those from Europe, Eastern Europe, Central Asia, Southeast Asia, China, Japan, South America, the predominant mode of infection here is mainly from sexual and percutaneous modes, whereas in Africa and Sub-Saharan Africa, it's more from mother to child. And this is the reason why in pregnant women, they are screened usually at the beginning of their pregnancy for hepatitis B. But what's the situation in Ghana like? We looked at the case of West Africa. Ghana is no different. A study in a systemic review and meta-analysis that was done by Euphoria Senso and Ajima in 2016, where they looked at data from 1995 to 2015, and they estimated the accrued seroprevalence at around 12.3%. And in another study that was done by Ivonate et al. 2022, they also looked at it from 2016. So exactly where Euphoria Senso and Ajima ended their study. So they looked at it from 2016 to 2021. And their accrued seroprevalence estimation was about 11.4%. So it's not too different. It means that we are still very endemic and not much has changed with regards to our endemicity. So we have to take the steps to make sure that we mitigate some of the side effects and complications that can happen as a result of the infection. And we know also that hepatitis B and C are currently the leading causes of liver carcinoma in Ghana. And in 2017 alone, the Hepatitis Foundation of Ghana reported about 4 million Ghanaians living with either hepatitis B or C. And sadly enough, majority of these people are not aware of their status. So this is just looking at the trend of reported cases, and this data is from the District Health Information Management System from the Ghana Health Service, and it was published in 2016. You can see that the number of cases that were reported had a steep rise from 2013 to 2014, where we're doing about 8,000 to 51,000 cases. And I'm not sure what happened around that time. Maybe we increased our vigilance and our testing, and that's how come we're able to record these number of cases. So the burden is still pretty much quite high in Ghana, and we have to take the steps to make sure that we protect ourselves. I will just go through the virology and a few things about the virus itself and how it behaves. All the hepatitis viruses are RNA viruses except hepatitis B. So it's the only exception in the family, and we know it belongs to the partner viridic group of viruses. It's circular, partially double-stranded DNA, and this is very critical and important to understand because it will be useful in the understanding the pathogenesis or pathophysiology of how they replicate. And it's been said that it's the only virus that actually carries, just like the retrovirus, it also has a reverse transcriptase. So it carries a DNA polymerase, which has both DNA and RNA dependent functions. And that is what is known as the reverse transcriptase. And in the pathophysiology and the replication, we understand how important this function of the virus is. And of course, hepatitis B has the highest prevalence among all the hepatitis viruses, and is one of the few viruses that has a direct oncogenic potential. This means that they can directly cause cancer. So just like the HPV virus for cervical cancer, this is also one of the viruses with very, very, very serious oncogenic potential and can cause liver cancer, what is otherwise known as hepatocellular carcinoma. And if you look at the viral structure itself, you see the envelope, and the proteins that are just around the envelope are what we call the surface proteins. Then inside the core, we have our E antigen or the core antigen. So the core antigen is somewhere here, and the E antigen is deep within, buried within the nucleus. And this is usually released when you're having active replication of the virus. And I said that the virus is highly infectious. It's been estimated that the virus can survive outside the body, especially in dried blood on the surface, for at least 7 days and still remain infectious at the time. And you don't even get this level of infectivity with HIV. But how do they replicate? Now, this is the reason why it's very difficult to achieve cure or cure people with hepatitis B, and it's because of how the virus behave. And most of it is still even not completely understood by us. So this is the virus, which if you are exposed to the virus, they infect your liver cells or the hepatocytes, and they go straight to the nucleus of your hepatocytes. So I'm going to summarize this in a few easy steps using the diagram. So now when they bind to the surface, they are internalized and they go straight into your nucleus. Now, after these viral particles have embedded your nucleus, they are repaired. Remember, I said it's a partial circular double-stranded, circular partial double-stranded DNA. So if you look at this picture very well, you can see that the outer strand is complete, but the inner strand is not complete if you look at it carefully. So you have a deep red outer strand and the inner strand is not complete. That's what we mean by partial double-stranded. So this has to be repaired. And unfortunately for us, this process that happens, it happens by the body's, is aided by the body's own host enzymes. And we don't even know, in a process that is not completely understood. So when they get into our nucleus, we help them repair this partial double-stranded, and they form this cccDNA, which is the covalently closed circular DNA. And this is the reason why it's so difficult to cure the virus, because once this cccDNA is formed, this becomes the template for which the virus undergoes its translation to form their protein. So it's first transcribed also with the Hope DNA polymerase. Then they are translated into the cytoplasm of the cells. Then because they have this reverse transcriptase, now these proteins that have been translated are then transcribed back into viral capsids, and the whole process is recycled. They go back into the nucleus, and it just continues. And now, for those that are not recycled back, they bud into the endoplasmic reticulum, where they are enveloped and they are able to exit the cell and affect more hepatocytes. And the process just keeps on and on and on and on and on. So if you're wondering why it's so difficult to cure this virus, is because of this stage. This is the rate limiting step, where we repair the partial double-stranded DNA to this CCC covalently closed circular DNA, and it becomes a template for active viral replication. There are various genotypes, about 8 genotypes or subtypes, and it's also one of the reasons why for some people they progress very fast to have hepatocellular carcinoma, and for others it takes a while before they develop, and because of the strains. And if you see in West Africa, the commonest strain is genotype E, but in other parts of the world, especially in Asia, you have genotype B and C being the most predominant. And it's been shown that the genotypes A and B, they have higher rates of antiviral response and E antigen loss compared to the other genotypes. And the ones that are more frequently associated with severe liver disease and hepatocellular carcinoma is actually the genotype C, which you see a lot in East and Far East Asia. Now, let's say you're exposed to the virus. What happens? Once you're exposed to the virus, there are a few things that can happen. One, you develop an acute infection. Well, this presentation, we are limiting ourselves to chronic hepatitis. So we will not talk too much about the acute infection. So once you're exposed to the hepatitis virus, it is said that most of the cases we get actually, cases who come in with chronic Hep B are people who have been exposed from infancy. So those are the people that I mentioned earlier that they had the vertical transmission. So once you are exposed during your period of adulthood, you are less likely to develop chronicity. Chances are that your body would get rid of the infection, then you would not be able to develop chronicity. So just under 5% of people who acquire the infection in adulthood will become chronic. However, 95% of the people who acquire the infection in infancy or in childhood will become chronic. And once you develop chronicity, that can easily lead to chronic hepatitis. You develop cirrhosis, and in 6 to 15 years, and in 5 years, 6 to 15% of those people may develop hepatocellular carcinoma, which may eventually result in death without a transplant. And 20 to 23% of those who get the infection in infancy will develop liver failure, which may also eventually result in death without a transplant. So you can see that it's actually it's actually better to get the infection in adulthood because chances are that your body will clear it. But to get it in infancy, chances are that 95% of the time you will develop chronicity. And that's why we don't play with the pregnant screening for the pregnant women, because that's where it all starts from. I don't know if I can be heard adequately. I think I got a message that the network is quite bad.
No, we can hear you loud and clear.
Okay, thank you very much. So what are the risk factors for transmission? Just like other highly infectious diseases that can also be acquired sexually, men who have sex with men, inmates of correctional facilities, injection drug use, persons with other co-infections like hepatitis C and retroviral, pregnant women, people on dialysis, transfusion. This is something we already know, so I'm not even going to go too much into it, but if you have any of these risk factors, I think it's about time that you go and test. You have multiple sexual contacts or history of STDs. You are born, and you see the last point here, if you are born into a country with high or intermediate prevalence. And we just learned that Ghana is also actually one of the countries with very high prevalence. So just by being born in Ghana puts you at risk and puts your lifetime risk of acquiring hepatitis B at 60%. It's very sad. How is it transmitted though? And we know it's transmitted through body fluids or contaminated blood. So if you come into contact with any of those infected body fluids or blood, or even sharp objects that have been contaminated with infected blood, you're at risk. And also it may be sexually transmitted. And I just showed to you, in our parts of the world, sexual transmission is not that predominant. However, in Europe and other places, sexual transmission is very predominant. The most important mode of transmission for us is mother to child. And in utero transmission is rare, even though it's been reported, it's quite rare. It's mostly perinatal, just around delivery, but it's actually the most important mode of transmission for us in sub-Saharan Africa. And of course, tattooing, body piercing, acupuncture, and all those things. So when you're taking a history, it's important to ask all these risk factors. And this table just shows the concentration of the virus in various body fluids. And as you can see, blood and serum and wound exudates have the highest concentration compared to urine, stool, breast milk, sweat, or tears. And that's why breastfeeding is not contraindicated in pregnant women with who deliver with hepatitis B. Then this is still looking at the risk of developing chronic hepatitis after you get the acute exposure. And you can see that perinatal. So if your perinatal E antigen positive mom has about 90% risk of chronic infection, a lifetime risk of hepatocellular carcinoma is about almost 40%. And for those, the horizontal transmission, you realize that the risk is actually quite lower. So the pregnant women, once again, should be the focus if we really want to eliminate this. But what is the natural phase or the natural history of chronic hepatitis B? Now, before I go into the new terminology, I just want us to familiarize or refresh our memories for those of us who already know this with the old terminology. And in the past, we've always talked about, oh, this person is in the chronic inactive phase, this person is in the immune tolerant phase, this person is it's good, it's nice, but we don't use those terms anymore. So traditionally, we have four phases traditionally, and this is quite old, but it's quite relevant to the new terminology. So I want us to just refresh our memories. So in the past, if you had hepatitis B, of course, it has to be chronic, and you've had the persistence of the antigen, surface antigen for more than 6 months, then your ALT values were normal. Your E antigen was positive, your viral load was high, but your liver histology was normal, and your ALT values are normal. You attempt to be in the immune tolerant phase. So basically, it means that your immune system has been able to somehow control it. So but one must know that you must not necessarily go through the phases or the natural history sequentially. Sometimes you can have people jumping the stages, and you can have people starting from other places. So traditionally, it was the immune clearance phase, or what we know as the immune active phase, and the immune escape or the immune reactive phase that we treated. So if you can see the table, treatment here is yes, yes. And this is because these were the phases that you had high levels of ALT. And we would come to understand that ALT is a surrogate marker for inflammation. So if you really want to assess an active disease, ALT is actually one of the most important things that you look at. Then this is just looking at the phases. So as you can see, the first phase, which is the immune tolerant phase, your ALT values are low. You still have high levels of viral DNA. Then when they go into the immune clearance phase, your ALT begins to rise sharply, and you reach your peak at the immune clearance phase. And now we don't call it that anymore. We call it E antigen positive chronic hepatitis. I'll show you a table that talks about the new phases. But you can see that even though your ALT rises very sharply at this stage, you can still have spikes in your ALT. And even though your viral DNA drops nicely at this stage, it can also have spikes. So if you realize the two stages where we have the spikes, those are the areas that traditionally we used to treat. And somebody can be in one stage for a very long time. It's believed that the people in the first phase, for instance, which is the E antigen positive chronic hepatitis B infection phase, they can be there for up to 30 years. It can be there for 10 to 30 years. So you can be in one phase for a very, 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 very long time. That's why it's important that when you see a patient today and you think the patient does not qualify for treatment, it's important to follow the patient up, because patient can easily move from one phase to the next. And those that are in phase 2, they are the ones that I said earlier that have the fluctuating levels of the ALT and viral load, and usually have them in the second or third decade of life. And in the immune clearance phase, which is the second phase. So the next phase, the inactive phase, which is now known as the chronic Hep B, E antigen negative chronic Hep B infection phase. They are the phase, that's the phase that traditionally we term the chronic inactive phase. We don't treat this phase. And that phase, normally your ALT is low, your viral load is low. Most of the time, everything is down, and there's really no indication to treat in this phase. And this is just a table that is putting everything together, showing the old terminology with the new terminology. So now the new terminologies we use is E antigen positive or E antigen negative. So if it's phase 1, which was the immune tolerant, we say E antigen positive chronic Hep B infection. Now stage 2 is E antigen positive chronic hepatitis B without the infection. Then the E antigen negative is E antigen negative chronic Hep B infection. Now, if you notice something interesting about the phases that have the infection, Anytime you hear infection, it means that the ALT values are normal. And it's very good for us as clinicians to be able to understand this terminology because it has implications for treatment. Now, if I say, oh, I have a patient who is E antigen negative chronic hepatitis B infection, immediately I'm telling you that this patient has ALT levels that are normal. So if the ALT levels are elevated, you don't add the infection. You just leave it at E antigen negative or E antigen positive chronic hepatitis B, and it ends there. And I hope this is very clear to a lot of people because I realize that sometimes it's still very confusing to my house officers and other doctors here. So anytime you are assessing a patient and the ALT levels are within normal range, depending on the E antigen status, is either a E antigen positive or negative chronic hepatitis B infection. If the ALT levels are deranged, then you don't say infection, you just say E antigen positive or negative chronic hepatitis B, then you end it there. And it's believed that phase 1 is actually the phase that is common in children or adolescents who have been infected from birth. So that's why they can be in this phase for a very long time, up to about 30 years. And those who are usually in phase 2, they are more frequently the ones who are infected in adulthood. And the outcome for those in phase 2 is usually quite variable. And of course, those in phase 3 is believed that that's where most of the E antigen, especially if you are E antigen positive, that's where the most of the seroconversion usually happens. So seroconversion, like I mentioned earlier, means that you develop the antibodies to the E antigen, and they can also have spontaneous loss of the E antigen in that phase. But how do we determine if someone has chronic hepatitis B? Because before we can treat anybody for hepatitis B, we need to make sure that they have chronic hepatitis B. So how do we do that? And like I mentioned earlier, when you have the surface antigen persisting for more than 6 months or 6 months or more after an acute infection, then it means you are chronic. It's as simple as that. It's very, 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 very simple. Once they come to you, you don't know them. It's the first time you are seeing them. You cannot just tell that it's chronic unless you know that they've had it for 6 or more months. Now, if you don't have the history, how would you be able to tell from the serology that they have chronicity? And that's what we'll find out. Now, for those that you do not have any history, no history, you are seeing them for the first time at the clinic, on the ward, or relatives, they call you friends. Oh, my surface antigen was positive. And I'm like, okay, how long have you known? I just found out. It doesn't mean that the person just got infected. It could be that the person may have been exposed for a very long time, but they are just finding out. So one of the ways to determine that from the lab is to request for the profile. Once you request for the profile, of course, you are going to have your surface antigen to be positive. Then you look for the core antibody. Once your core antibody is positive, chances are that they are chronic. Now, if the lab gives you the IgM and the IgM is positive in this case, then it means that it's an acute infection. But if the IgM is not given and they just state the antibodies to the core antibodies, sorry, they just give you the antibodies to the core antigen, or they just say IgM negative, surface antigen positive, antibodies to the core antigen positive, then it's chronic infection. So that's also another way to determine chronicity. Now, once the IgM to the core antibody is positive and the surface antigen is positive, then we know it's acute. And this is something we all know. How about if everything is negative? So that is somebody who has not yet been exposed, but that is somebody who is highly susceptible to an infection. So these are the people. So once everything is negative, these are the people that you advise to go and get the vaccination. But how do I know if somebody has been vaccinated? Now, if you've been vaccinated, the only thing that will be positive in your profile is the antibodies to your surface antigen. Remember that when we are doing the screening, the only thing that we check for the screening is the surface antigen. And the vaccine that is giving you is actually a surface antigen that is giving you a weakened form of the surface antigen. So the antibodies that your body will develop is the antibodies to the surface antigen. So if somebody has been vaccinated, the only thing that will be positive in their profile is the antibodies to the surface antigen. Once you are seeing the antibodies to the surface antigen and you're also seeing core antibodies, it means that this is somebody who has had a prior infection and has probably resolved. So let's take note of this. It's also one area that is quite confusing for a lot of people. So they give you a profile and they tell you don't understand their profile. What does it mean? So this is one very easy way to try and figure out what each means. Remember that the surface antigen is what is tested. So if all you have is a surface antibody, then it means you are the one who has been vaccinated. However, if you have the surface antibody and the core antibody, then you are likely to have been exposed by your body as the infection has resolved. And I hope it's clear. If it's not clear after the presentation, we can go through again. So how does one who has chronic, now we know how to determine chronicity, but how would they present? And I'm very sad to tell you that majority of them will be asymptomatic. So they will not come. You will not pick them up unless maybe incidentally they go and do some health screening somewhere, or they are tested somewhere. Majority of them will be asymptomatic and they would only have serological and histological changes. So they may be fine. The day they come with symptoms could be the day that you diagnose your cirrhosis, decompensated cirrhosis, or your hepatocellular carcinoma, or maybe they are coming with with a extrahepatic manifestation. So majority of them will be asymptomatic, and a few of them may come in with non-specific symptoms like general malaise, fatigue, nausea, poor appetite, and non-specific abdominal pain. And especially for those who may come up with an acute flare or a reactivation, they are the ones that may come in with these acute symptoms. Physical examination may also be normal, and you may or may not pick up any stigmata of chronic liver disease. For those that may come in with decompensated cirrhosis, then you may find splenomegaly, ascites, peripheral edema. They may come in encephalopathic and all that. But who do you treat? Now we know how to determine chronicity, but who do we treat? Because I mentioned that it's not everybody that has hepatitis B, right, will require treatment. So that means that there's a subgroup of people that may not require treatment and a subgroup of people that may require treatment. Now, treatment basically depends on what we call active disease, right? And active disease activity is defined mainly by a few things, just three main things. To make things very easy for us: the ALT, the viral load, and the presence of liver inflammation. If we remember these three things, we will never ever struggle with determining who to treat or who not to treat. Remember, we said at first we only treat those who are chronic. We've learned how to determine chronicity. And now we are saying that we only treat those who are chronic and have active disease. Active disease means that their ALT level is high. Remember, I said the ALT is a surrogate marker for inflammation. So they should have high ALT levels. There should be evidence of liver inflammation, what we call necroinflammation. Then there should be high viral load. So those are the three things that we'll mainly look at. Whatever guideline you are using, whatever treatment, practical, clinical practice guideline you are using, the goal of therapy is the same. And our goal of therapy is to make sure that we improve their survival and their quality of life by preventing disease progression and development of hepatocellular carcinoma. That is the first and foremost goal. We want to improve their survival and prevent HCC from developing. Then we also want to prevent mother-to-child transmission, B reactivation, and prevent and treat any other complications or extrahepatic manifestations. So basically, this is the goal of therapy. But once you start therapy, you should be clear in your mind the target or the end point of your therapy. Otherwise, you just be given a medication, you wouldn't even know what you are doing. The main endpoint or the main target is to induce long-term suppression of your viral load. And that's what I put here in this very first step. The main thing is to induce long-term suppression of your viral load. But the optimum endpoint, what we all pray and what we all hope and what we all fast and make sure that our patients get is to ensure that we achieve what we call surface antigen loss with or without seroconversion of the surface antibody. So what that means is that, remember that when we are screening, we screen for the surface antigen, and that's the protein that's usually coated on the envelope of the virus. And if we are able to achieve loss of this surface antigen, whether or not they develop the antibodies to the surface antigen, it's our optimum endpoint. That is the main optimum, but that is very rare. Some surface antigen loss or functional cure is so rare that it's less than about 2%. even worldwide, elsewhere where they have everything they need. So you realize that it's very difficult to achieve this. But the first one, which is this, we can achieve, and that is in a suppression of their viral load. And a valuable endpoint, and this is only for those who have e antigen positivity, and that's also to have e antigen loss with or without development of the antibodies to the e antigen. And an additional endpoint here is to for our ALT to normalize, which we call biochemical response. We'll look at the responses later. Now let's quickly look at the guidelines since we don't have all day. Now, there are so many guidelines, and putting this presentation together, I had to review all the guidelines and only present the ones that I think are still quite relevant. This presentation focuses heavily on the most recent guideline, which is the WHO 2024 guideline, which was released just March last year. And I realized that a lot of people are still not familiar with it, so it's a good time for us to go through. However, the 2017 ESOL guideline was still a very valuable document in putting this together because not too much has changed from the ESOL guidelines that were released in 2017. And ESOL means European Association for the Study of Liver Diseases. Of course, there's a national hepatitis treatment guidelines from Ghana with contribution from HEPSOC, which was published in 2016. Then there's the ASLID, which is the American Association for the Study of Liver Diseases. They also have their guidelines. So I'm starting with the national hepatitis guidelines, and this is what we all know. So I decided to just project this one just for us to refresh our memories, then we'll learn the new one. And if you look at this guideline talks about who should be treated. Now, in the past, before we treat, we'll say that you have to do your profile. We have to find out whether you are e antigen positive or not. If you are e antigen positive, then the viral load cutoff should be 20,000 international units per mil. Then if you are e antigen negative, then it should be 2,000. I'm sorry to tell you that this is no longer the case, but I projected this so that at least we can refresh our memories and know the new one. So now let's look at the WHO guidelines, which is the one from March. So who do we treat? Now, WHO decided to expand the eligibility for treatment to capture about 20 to 35% more of the people with surface antigen. They realized that there were a lot of barriers to treatment, a lot of barriers with the old guidelines because people, especially for those in sub-Saharan Africa and very, very poor countries where people cannot afford viral load, people cannot afford to do a lot of the testing. They put a lot of barriers to treatment. So they were not reaching the target. So they made this very simple treatment eligibility criteria to be able to catch and capture a lot more people so that they can remove the barriers that were either to to treatment. So now this new barrier, there are just 4 things I'm interested in. So if you have a patient and you call me to discuss, there are just 4 things I'm interested in. And this is for adolescents and adults, okay? Non-pregnant adolescents and adults. Now, the first thing you look at, is there any evidence? And like I said, we only treat active disease. And I told you that active disease means either your ALT is high, viral load is high, or there's liver inflammation. These 3 things, they are the only things we need. So the first thing is there evidence of liver fibrosis? Is there evidence of liver fibrosis? Now, WHO in the past, they in assessing for liver fibrosis, in people with chronic Hep B, we don't routinely do histology. We don't biopsy. It's not routine. There are indications for biopsy, but there are strict indications for biopsy. We don't routinely biopsy them. So what the WHO recommends is that you do the non-invasive ways of assessing for liver fibrosis. And in the past, liver fibrosis, the treatment was only targeted at liver cirrhosis. Now it's no longer the case. Treatment is also targeted at significant fibrosis. Later on, we will learn about how to estimate for significant fibrosis. But there's something we call the APRI score. So in the past, we were using an APRI score of 2. APRI score of 2 means that you have some cirrhosis in your liver. Now, they review the APRI score down to 0.5 to represent significant fibrosis. So you don't have to wait till the patient develops cirrhosis before you treat. Once there's evidence of significant fibrosis, you have to treat. So if you can see, all this thing is saying, I summarize in these very 4 simple points. Is there any evidence of significant fibrosis? What that means is that you have F2 or above, APRI score of more than 0.5. I'll explain what it means. Or F4 for cirrhosis. So this or, if you see or, it means that either this or this. You don't need this and this. Viral load, like I said, now in assessing for who to treat, you do not need to know the E antigen status. It's not necessary. All you need is a viral load. If the viral load is more than 2,000, whether they are E antigen positive or E antigen negative, once the viral load is more than 2,000 with an elevated ALT, and now WHO has reviewed the cutoff point for ALT even further down. I know with athlete, like the Americans, they use 35 and 25. And in the past, the European ESOL guideline, they use 45. Now, WHO has reviewed it further down, 30 for men and boys, 19 for women and girls. So that's what we use. We don't use 45 anymore. We don't use 25 or 35. If the viral load is more than 2,000 and your ALT is more than 30 for men and boys and 19 for women and girls, you have to treat them. If they have co-infections, comorbidities, including diabetes, type 2 diabetes, family history of cancer or hepatocellular carcinoma or cirrhosis, extrahepatic manifestations, they're on cytotoxic therapy, anything that suggests any form of immunosuppression, you have to treat them. So the third point is co-infections, comorbidities. And the interesting thing about this point is that they've included people with type 2 DM because they found out that diabetes is one of the things that accelerates progression of liver disease. So even those with fatty liver, metabolic dysfunction associated fatty liver disease, they have to be treated. Then if you don't have viral load, so for those in the villages where or your patients cannot do viral load, if you have an ALT that is more than the upper limit of normal in a 6 to 12-month period, so your first ALT was maybe 35 or 40, and your next ALT is about 55, and it's within 6 to 12-month period, you can treat. So the WHO has really simplified it for everybody and for all of us so that they can remove the barriers to treatment. So now there are just 4 things you need to know. One, is the ALT elevated? If the ALT is elevated, we don't use just the ALT. You have to use the ALT with the viral load. However, if you cannot do viral load, then you need an elevated ALT in a 6 to 12-month period. So you need 2 values that are elevated in a 6 to 12-month period. Are there co-infections like Hep C, retroviral infection, TB? Are they on dialysis? Are they taking immunosuppressive therapy? Do they have comorbidities like DM, cancer, cirrhosis, any of those things? Do they have extra? You have to treat complete. So these are like co-infections, comorbidities, complications. Then the last point is there liver fibrosis. But like I said, we don't biopsy routinely. So because we do not biopsy routinely, what do we have to do? We have to use the non-invasive methods of assessing fibrosis. And WHO has recommended 3 main non-invasive methods of assessing fibrosis. And the first one is what I've been talking about, the APRI score. APRI score means AST platelet ratio index. Now, this is such a gold mine and such an important tool that I wonder why we don't do it often. So now, here, every patient that is presented to me with chronic Hep B, you have to tell me about the APRI score. Otherwise, I'll not listen to you because it's such a simple, non-invasive method of assessing for fibrosis. Very simple. And all you have to do is you already have your full blood count. So you'd have your platelets and you would have your liver function test. So you'd have your AST. All you have to do is divide your AST by the upper limit of AST, then divide everything by the platelets and multiply by 100. Now, WHO has recommended that for the people from sub-Saharan Africa, low-income settings, APRI should be the preferred non-invasive method of assessing fibrosis. However, those in Europe, other places, what they use is what we call the transient elastography, that's the fibroscan. It's just like an ultrasound machine, but it uses sound waves to detect the stiffness in the liver. So it's actually quite expensive, and this table compares the APRI score, the FIB4, and sorry, I beg your pardon. This table compares the APRI score, the FIB4, and the FibroScan. And you can see in terms of cost, the FibroScan is like 3 times. The FibroScan is very expensive, over $25,000, and you need people to train and all that. So why don't you just calculate your APRI score? Then this APRI score will now help you determine if the patient has fibrosis. So now, what do I mean by this patient has fibrosis? So let's say you calculate your APRI score and your APRI score is 0.5. Now, if you want to, like I said earlier, now we don't wait for them to get cirrhosis. Remember that cirrhosis is a continuum, and I intentionally put this here. The APRI score was based on the Metavir staging of cirrhosis. So we have F0 and F4. Now, for those who are at F0, it means they don't have any cirrhosis. So these are people who have been biopsied, right? And when they biopsy you and there's portal fibrosis without septa, they put you at F1. If there's portal fibrosis with septa, they put you at F2. If there's numerous septa without cirrhosis, they put you at F3. If there's evidence of cirrhosis histologically, they put you at F4. Now, a lot of meta-analysis and systemic studies were done, and they realized that an APRI score of 0.5 corresponds to at least F2, which is significant fibrosis. And an APRI score of 1.0 corresponds to cirrhosis, which, so if you do your APRI score, the lower limit or the lower cutoff of significant fibrosis that you are looking for is F2, and that is your 0.5 based on your Metavir staging. So anybody in the past, we were using an APRI score of 2, but an APRI score of 2 means that patient has cirrhosis. If you can see here, this is the lower limit for cirrhosis, it is 1, and the upper limit is 2. So if your APRI score is 2, it means that this is an established cirrhosis. If your APRI score is 1.5, it means that patient has at least F2 on the Metavir staging because the lower limit is 0.5. And if you are using the transient elastography, then these are the values that you get. So now if you come back to this WHO, now that we understand this, if you come back to this WHO measurement, you see clearly what they mean and you'll be able to understand what they mean. So what they said was, if there's evidence of significant fibrosis, that is F2 and above, so like we said, based on an APRI score of more than 0.5, or a transient elastography value of more than 7 kilopascal, or any evidence of cirrhosis, that's F4, based on clinical criteria or APRI score of more than 1 or transient elastography value of more than 12.5, regardless of their viral load or ALT levels, you have to treat. Do you see how profound this statement is? This statement is so profound that it means that if I have a patient who comes and I calculate my APRI score, and my APRI score is 1.0, it means that I don't even need my viral load. Already, 1.0 puts the patient at cirrhosis, not even fibrosis. And cirrhosis is F4. That means patient's already at the latter tail end of the cirrhosis spectrum. So that means that I don't even need my viral load to be able to initiate this patient on treatment. That is how profound it is. And I get surprised when people do not calculate the APRI score because so far, every APRI score I've calculated that I've linked to ultrasound findings, every APRI score that I've calculated that has been more than 0.5, there has been a corresponding ultrasound findings of cirrhosis or fibrosis. And I've not seen, even though it's not 100%, I'm yet to meet one that did not correspond, but it is quite sensitive. So we should, and that is what the WHO recommends that for those of us in low-income countries, we should do. So this basically puts everything into perspective. So we need one, evidence of fibrosis. We need a viral load and ALT, co-infections or comorbidities. Then if there's no viral load, just the ALT, and that's enough for us to treat. Okay. All right, so I projected the Ghana hepatitis treatment guidelines. I've gone through the WHO most recent guidelines. I just put the ISL 2017 guidelines because it's still one of my favorite guidelines and it's still very relevant. And you see that what has changed is that now we are no longer using a DNA of more than 20,000 and an ALT of more than 2 times the upper limit. So that is what has changed. That's the most significant thing that has changed the new WHO guidelines. So now, irrespective of your E antigen status, when your viral load is more than 2,000, once your ALT is also more than 30 for men and 19 for women, you have to be treated. Remember that when we are using the viral load, we don't use just the viral load. We use the viral load with the ALT. But when you are using the fibrosis, comorbidities, complications, you can use them alone. You can also use ALT alone if it's within a 6 to 12-month period and you have more than one reading. That's abnormal. How do we select the appropriate drug for treatment? And then again, I also take you back to the WHO new guidelines. It's not too different from the old guidelines, except that these days we don't use the lamivudine and adefovir and the telbivudine anymore. We don't use them anymore. Now, first line is tenofovir. Tenofovir, disoproxil fumarate, tenofovir, alafenamide, and entecavir. Those are the drugs, and nothing more, nothing less. Pegylated interferons still have a role, a very strict criteria for use. If you look at the ESL 2017 guidelines, they compared the use of entecavir, tenofovir disoproxil fumarate, and the tenofovir alafenamide with the pegylated interferons. And if you read most literature, they will tell you that yes, the pegylated interferons still have a role, especially for people who do not require or people who do not want indefinite therapy. They want a finite therapy. They have higher levels of inflammation. Those people tend to benefit more from the pegylated interferons because the treatment duration is fixed at 48 weeks. And also it's been shown that women also tend to benefit better. But of course, do not use pegylated interferons in pregnant women. It's contraindicated in pregnant women. It's contraindicated in people with cirrhosis, decompensated cirrhosis. And it also has very severe renal toxicity. So the first line still remains tenofovir and entecavir. And you can use the tenofovir either for, you can use both tenofovir for even people with renal impairment, except that we prefer the tenofovir alafenamide for those with renal impairment. Not because you cannot use the disoproxil fumarate. You can use it, but you use it at renally adjusted doses. And the thing with the alafenamide is that you don't need to adjust the dose. That's why we prefer it, unlike the disoproxil fumarate. Of course, for those with severe bone issues, issue of osteoporosis and all, you want to stay away from the disoproxil fumarate. You go for the alafenamide. And there are other reasons why you may select the entecavir or the TAF over your disoproxil fumarate. If everything is okay, go for your disoproxil fumarate. And the reason why we've stopped using the adefovir, so you can see this chart. This chart looks at lamivudine, this is lamivudine, this is adefovir, and this is telbivudine. Like I mentioned, we stopped using all of them because they have such low barriers for resistance. And this graph is from the ESL 2017 guidelines. It's looking at treatment of people with chronic hepatitis B by year 5, from year 1 to year 5. By year 5, see, year 1, you had about 24% of the people being resistant. By year 5, 70, as much as 70%. Lamivudine is like on the floor. It has such a low barrier for resistance that now we don't even use it anymore. And if you are going to do lamivudine, the recommendation is that you do lamivudine. You don't do it as a monotherapy. You do for those that may, for some reason, cannot tolerate your tenofovir or entecavir. If you want to do lamivudine, you have to combine it with either your tenofovir. You cannot do it as a monotherapy. You still have to add your tenofovir. Or sometimes you can do your tenofovir disoproxil with emtricitabine. If you look at adefovir, by year 5, 29% of the people were resistant. And if you look at the telbivudine by year 2, 17%. Now look at the resistance for tenofovir alafenamide and tenofovir disoproxil, zero. And entecavir was very small. And that's why these drugs are now the go-to and the gold standard for managing chronic hepatitis B. Now we started monitoring. How do we assess for treatment response? And of course, once you put any patient on any drug, every time you have to be monitoring them because Hep B is so smart that sometimes you can have patients who are even very stable, very fine, very stable. They are not on treatment. They are fine. Then the next time they rush them to the hospital, they've developed cirrhosis. And I've seen quite a number of people like that, and it's really heartbreaking. And I'm sure that's why WHO has even reviewed the ALT levels further down so that we can capture more people and prevent the ALT even from going. Why do you wait for ALT to be more than 2 times the upper limit before you treat? Why don't you rather prevent it or stop it from going to 2 times the upper limit in the first place? That's why they review the cutoffs very low so that we can capture more people. And I won't be surprised if there comes a time where now they'll say that once you test, we should treat, just like it happened for HIV. So at least every year, you have to monitor them using our non-invasive test. I talk about the APRI score. So your AST platelet ratio index, or if you are in America or somewhere else where you can do the transient elastography scan, you do that. And you do that to assess the stage of disease. Then, of course, to assess for progression, to assess for progression to cirrhosis or hepatocellular carcinoma. You have to check their ALT levels, their viral load. Of course, elsewhere, they can do the quantitative test for the surface antigen level. So they also do that. Here, most of the time, we don't do the quantitative test for the surface antigen levels. We just do the qualitative one. And of course, you have to counsel them. I've seen people who come to the clinic, we put them on tenofovir, they take for a month and they stop. They come back 3 months time, said, oh, but you didn't tell me that I should continue. Meanwhile, almost the whole time you were talking about continuing the medication. So it's important every time they come, assess for treatment adherence and monitor them. Now, for the first year, you can do 3 to 6 monthly before you go to annually, especially for those who come in with advanced disease, whether compensated or decompensated cirrhosis. And for those that you think that treatment adherence will be a concern, and for those who have co-infections, comorbidities, those who have renal impairment, you don't have to start off annually. For such people, you do 3 to 6 monthly before you switch them to annually. Now you started treating them. How do we ensure that we are getting a response from the treatment? You have to assess for virological response. Now, virological response, there are different types of response. There are 4 main types of response. And maybe because of time, I'll not go through all into detail, but we have the virological, serological, biochemical, and histological response. Now, once you start them, you expect, so let's say a patient comes to you, viral load is 2 million international units per mil. And please, the viral load units you are interested in is not the copies per mil, it's the international units per mil. If for one reason or the other, the lab gives you copies per mil, you can divide that by 5 to get the international units per mil. One international unit per mil is about 5.3 copies per mil. So it's easier to just divide it and get the international units per mil. That's what we are interested in. So 2,000 international units per mil will be about 10,000 copies. So if you forget the 2,000 international units per mil, you remember 10,000 copies per mil. So that's our cutoff. Whether you are E antigen positive or you are E antigen negative, is the same thing. These days, and with the most current guideline, we don't discriminate like that. Now, when I start the treatment, what they are saying is that I expect that after 3 months of therapy, there will be about a 10-fold reduction in the viral load. That's what we mean by that's what we mean by a reduction of 1 log 10. Okay, 1 log 10 is a 10-fold reduction. So what you have to do is, if it is let's say 20,000 IU per mil, just divide it by 10. Then that will be 2,000. So after 3 months of therapy, we expect that your viral load would have dropped from 20,000 to about 2,000. That's what it means, 1 log 10 reduction. And there are some people that after even a year, even though they've achieved less than 1 log 10 reduction, they still have detectable DNA levels. And those are the people that we call partial virological response. Okay. And for those who for a very long time, their viral loads have been normal, they've reached another where they have a very stable and low viral, then all of a sudden they get more than 1 log 10. That's a 10-fold increase. We call them virological, they've had a virological breakthrough. The next response is serological response. Serological response just means serology. So if you are E antigen positive, I'm expecting that you would have achieved E antigen loss with or without seroconversion. And if you are surface antigen positive, which of course you would be if you are chronic B, would expect that you have a surface antigen loss and seroconvert. And that is what we expect for everybody. And that is the optimum cure or the functional cure, which we struggle to get. And the reason why we struggle to get that is because of that CCC, covalently closed circular DNA, that you usually have in the nucleus of the hepatocytes when the virus is internalized into the nucleus. And of course, histological response, because we do not routinely do biopsies, you may have to assess histological response with the APRI score or your FIG-4 score, okay? And biochemical response is when your ALT now normalizes. And I have to sound this caution that even in patients who have achieved whether it's serological or virological response, and you still have to monitor them closely, even those that may have achieved functional cure, especially if they developed cirrhosis before achieving functional cure, are still at risk of developing hepatocellular carcinoma. That's how serious hepatitis B is. The treatment failure talks about two main types of treatment failure. The primary treatment failure is just like your partial response, so I'll not go too much into them. And of course, this diagram is from the ESOL guidelines, also talking about monitoring, which I've already spoken about. So I'll just skip it for time purposes. Every patient with chronic hepatitis B, you have to do surveillance for hepatocellular carcinoma, because that we do not even want them to develop hepatocellular carcinoma. So you have to do your surveillance. Now, how do you do your surveillance? You can start from every 6 months. You do your ultrasound and you do your alpha fetoprotein levels, especially for those that may have come with cirrhosis, whether compensated or decompensated, regardless of their age or other risk factors. And those with family history of hepatocellular carcinoma or even cirrhosis, okay? And those who are older than 40 years, and those whose viral load was more than 20,000 international units per mil. When do you stop? When do you stop? And before that, I have to say that therapy is lifelong. But there are indications where you can't stop therapy, and that decision shouldn't be done by you. It should be done by a gastroenterologist or a specialist. And this is from the ESOL 2017 guidelines. It's not too different from the WHO March 2024 guidelines. So that's why I didn't reproduce both. I just brought one. It's very much the same. So you may stop if they achieve surface antigen loss. And this is what we've already spoken about as functional cure. And less than 2% of people will achieve functional cure, with or without seroconversion. That means that whether or not they develop antibodies to your surface antigen, once they achieve functional cure, you may stop. But even if you look at this, it's about grade 2 to level 1 recommendation. It's not 1. So it tells you that this recommendation is not from randomized control trials, from like case cohorts or case control studies. So it's not even a very strong recommendation. Now, for people who were E antigen positive, who did not have cirrhosis, who were able to seroconvert and have had undetectable levels of viral load, and you've also done 12 additional months of consolidation therapy, you can stop. And for those who are E antigen negative without cirrhosis, who have been on the medications for 3 or more years and have achieved virological suppression, provided you can provide close monitoring, you may stop. So you see, it's difficult. It's difficult to get this. And even for people who get this, if you cannot ensure that you, you can closely monitor them, it's not recommended that you stop. But in our part of the world, I must put this emphasis that we do not recommend stoppage. If you look at the WHO 2024 guidelines, they will tell you that antiviral therapy is lifelong and it's stated categorically, and it will give you the indications where you can stop. So unless you can really monitor, unless you've even done your 12 months of consolidation therapy, even after they've had undetectable levels, you've done 12 months in addition, unless you can do any of these things, please let them know that the therapy is lifelong. Okay, so now look at the last part of the presentation, which looks at management in special populations. And pregnant women is so important because that is where, for us, it all starts from. Most of our people with chronic hepatitis B were people who got it vertically, mother to child, perinatally, and also it's very important that we focus on them. Now, it's a lot here. I don't know if you can see very well, but the summary of everything is that if they are pregnant, this is the only time that you actually need the E antigen status of the woman and the viral load if they are pregnant. That's with regards to making treatment decisions. You still need E antigen status if you want to find out the cause, the phase that they are in and all that, yes. But when it comes to making a decision to treat them now, you do not need E antigen, except when they are pregnant. The reason is that because the WHO wanted to remove all these barriers, for those that you do not have access to viral load testing, if the E antigen is positive, according to the WHO most recent guidelines, you can treat them. So you are in a village somewhere, woman is Hep B positive, and you don't have access to viral load testing. And maybe you have to travel several kilometers before you can do it. She's about maybe 28 weeks or even 30 weeks. It's past the first trimester. You can treat them. However, if you have access to viral load testing, you have to get a viral load of more than 200,000 international units per mil before you put them on treatment. And I hope that is very clear for everybody, because that is where we have to focus on. And when they deliver, you have to let them make sure that the babies get the vaccine and the immunoglobulin, ideally within 12 hours, but it's allowed up to 24 hours post-delivery. And the immunoglobulin and the vaccine will be given at two different sites, and it has to be given immediately. Unless, of course, maybe there are other reasons for which the baby cannot take. Maybe they were born preterm and they were very ill, or they had some illness. But even with that, you have to discuss with your pediatrician or your obstetrician gynecologist. The babies must get the vaccine, and that vaccine or immunoglobulin is different from the vaccine they will get, which is part of your normal vaccination for the country in which you live in. And we know that in Ghana, they get a pentavalent vaccine. That one is not part. This one that you are giving them as prophylaxis because the mother was exposed. And I hope it's clear to everybody. So the cutoff viral load for pregnant women is 200,000 international units per mil. However, in places where you don't have access to viral load testing, if they are E antigen positive, you are allowed to treat. And tenofovir disoproxil fumarate is very safe in pregnancy and well tolerated. The one that is still not advised in pregnancy is the pegylated and even the entecavir. The studies are not too strong, but the tenofovir disoproxil they can do in pregnancy. All the patients who have co-infection, we've already mentioned, whether it's HIV, whether it's hepatitis D, whether it's hepatitis C, you have to treat them. And for those people, this is one of the few cases where you do not do monotherapy, especially those who have co-infection with HIV. So normally, luckily for us, the treatment protocol we use for our HIV patients, which is the dolutegravir, lamivudine, and tenofovir, has our tenofovir disoproxil fumarate at the same dose. So once they are on it, we know they are also covered for um, um, the hepatitis. And out of the about 34 million people with HIV worldwide, it's estimated that about 5 to 25% of them are living with hepatitis B, with the greatest burden in our low to middle income countries. So it's serious. So every patient that you're assessing for treatment, you always have to do the retro screen as well, and hepatitis C, because it has implications for treatment. And of course, those who are also hepatitis C, the recommendation is that you have to start treatment of the B during and after the same time you are treating the C. The reason is that when you start treating the C, you know the C can be cured, right? So you can do your C, but when you start treating the C, the sometimes, because the C, in many instances of co-infection, the C is the dominant virus. If you have a BFC co-infection, the C is usually the dominant virus. And there are times when it may even, in fact, suppress your viral load for hepatitis B. And sometimes when you, especially for those who have hepatitis B who have been in the chronic inactive phase, when you start treating the C, sometimes they can get a reactivation of the B. So anytime you are treating the C, if they have B, during the same time you are treating the C, treat the B. Then after you are done with the C, continue with the B. That's what they are saying, to reduce the risk of reactivation. And of course, we know that the D, which is the Delta virus hepatitis D, even though it can replicate autonomously, it needs the B for viral packaging and entry into the cell. So you cannot get an isolated hepatitis D. The D always goes with the B. You realize that for some group of patients, anytime they come, ALT is in the roof, but we do their viral load and viral load is low. You don't understand, why is the ALT so high and viral? Because we said ALT is a surrogate marker for inflammation. So if there's a lot of inflammation going on, why is the viral load so low? And the reason is that sometimes they have a co-infection with D. And because we don't routinely test the D, we miss it. And the WHO recommends that for all the patients that we are evaluating for treatment for hepatitis B, we should test the D. And the D, just like the C, you do the antibody testing. If it's there, if it's positive, with the total antibody is positive, you can do the IgG or the IgM, but usually the total is more reliable. If it's there, it doesn't mean it's an active infection. You have to do the RNA. Remember, I said all the hepatitis viruses are RNA except B. So you do your antibody. If it's there, you do your RNA. If it's there, then you treat. So, I mean, these are things that we need to take note of, because sometimes you have a patient, I'm not sure, is there a no-cause infection? Why is the viral load so low, but the ALT levels are high? It could be a co-infection with D. And two infections have been described with D. You could have a super infection, you can have a co-infection, but maybe because of time, we'll not go too much into it. But until recently, the pegylated interferons have been has been what most people have used offline since to treat hepatitis D co-infection with B. But now you can use the nucleoside analogs as well, your tenofovir and the likes. How about those who are on dialysis, chronic kidney patients? Like I said, tenofovir disoproxil fumarate is not contraindicated in dialysis or renal impairment, except that you have to do renal doses. And the renal doses can be annoying. That's why I prefer the alafenamide, because the alafenamide did not need any dose adjustment. If you look at this table carefully, and this is still from the WHO guideline, you see that for those who creatinine clearance is between 30 to 49, so these are about stage 3 CKD. The recommendation is that if you are doing tenofovir disoproxil fumarate, you do it 1 tab every 48 hours. So you can take 1 tab every 2 days, and it's allowed. But who wants to go through the stress of renal when you can just give them alafenamide without any dose adjustments and they'll be fine? That's why we prefer the alafenamide. Except when they have severe bone disorders, osteoporosis, and that one, the tenofovir disoproxil is completely contraindicated. You have to do just alafenamide or entecavir. However, even for the alafenamide, if their creatinine clearance or eGFR is less than 15 and they are not on dialysis, please do not give it to them. It's contraindicated. It's only indicated if it's less than 15 and they are receiving chronic hemodialysis. So I hope you take note of this very important point. How about healthcare workers? A lot of healthcare workers are walking around the clinics, the hospitals, and they don't even know their hepatitis B status. And it's very sad because you are exposed constantly to body fluids, most of which may be contaminated. You are exposed to blood, sharps, and especially the healthcare workers who do procedures, phlebotomists, dental surgeons, you do any procedure at all, you are passing tubes, you are always dealing with a patient body fluids of some sort. And we know that hepatitis B is highly infectious. Even on the surfaces in dried blood outside the body, it can be there up to 7 days and it can still remain infectious. Why haven't you checked your status? Why haven't you checked to know whether you have it or not? So that if you don't have it, you can take the vaccine and protect yourself. So for healthcare workers, the especially before you resume any exposure-prone procedure, before you deal with any patient, you have to protect yourself and the patient. If your viral load is not less than 2,000, you are not allowed to do any procedure on any patient. Please, let's take note of that. So for healthcare workers, it's still 2,000. So right now, the magic number is 2,000, except for pregnant women, which is 200,000. And the unit is international units per mil. And of course, like I mentioned earlier, all those on immunosuppressive therapy, whether you are retrovirus infection, you are on chemo, cytotoxic drugs, you're on biologics, whatever it is, please, if they have hepatitis B, treat it. Because if you do not treat and you start the immunosuppressive therapy, they may have a reactivation of the hepatitis B. And this table just algorithm simplifies everything I've spoke about. So I'm not going to go through them. And this is for the pregnant women. Like I mentioned earlier, the magic number here is 200,000, not 2,000. What are the complications? And the most feared complication is liver cirrhosis and hepatocellular carcinoma. And it's sad. It's sad. Just yesterday, I had to see a patient who came in with hepatocellular carcinoma and had been diagnosed with hepatitis B about 8 years ago. And he was lost to follow up. He just stopped going to the hospital, abusing alcohol, doing everything possible just to speed up his acceleration to hepatocellular carcinoma. And they come in, and when you tell them that, well, there's portal invasion, there's this, there's that, at this point, we can't do anything. The disappointment on their faces alone is really sad. So we don't want to get there. We don't want to get to hepatocellular carcinoma. We do not want to get to liver cirrhosis. We do not want you to have a reactivation. And there are certain complications that are outside the liver, which we call the extrahepatic manifestations. And now the main extrahepatic manifestations, glomerular disease and polyarthritis nodosa. And for those who know what polyarthritis is, it's a form of vasculitis. So polyarthritis nodosa is where you have a widespread inflammation of your medium-sized vessels. So you have a widespread, so they present with all forms of conditions, because almost all the vessels, medium-sized vessels in the body are affected. They can come with rash, they can come with anything that you can think of. The only thing that is spared is their lungs. And the two most commonest extrahepatic manifestation in people with chronic hepatitis B is polyarthritis, which is about 36%, and glomerular disease. So the glomerular disease, The most common is the membranous nephropathy. That's what most people know, form of etiological form of nephrotic syndrome. So they'll come in with nephrotic type proteinuria and all. Of course, membranoproliferative is less common. Other things like arthritis and cryoglobulinemia and the rest, they're also there. So how do we prevent? Because of course, we can't talk about hepatitis without talking about vaccination, prevention. Please, everybody here, tomorrow when you go back to work or you go back to wherever you would be tomorrow during the daytime, try and find time, go to any hospital and go and check your surface antigen status. If you are negative, go straight to the public health unit and go and request for a vaccine because you are susceptible. Just by being born in Ghana, you have a 60% risk of getting hepatitis B just by being alive. So why don't you want to protect yourself? Now, the vaccine, there are different types. There are some that you take 0, 1, and 3. There are some that you take 0, 1, and 6. I depends on what type of vaccine you are taking, but mostly it's 3 shots. So when you get all your 3 shots, after 1 to 2 months after you complete, please go back and tell the laboratory guy that you want to check for your titers, your surface antibody titers. Now, if your titers are more than 10, then of course, no further action is necessary. That's okay. You are okay. You are fine. If your titers are less than 10, please go back to the public health unit and let them give you another vaccine. They'll give you another shot, which you call the booster shot. If you take the booster, after 2 months, you can go back and check the titers. If they are still less than 10, you are allowed to take another shot. If you take about 2 shots and your titers are still less than 10, those are the people that we call vaccine non-responders. So please, that one, just come and see us. You can see any physician specialist. You can see your local medical officers. They may refer you. And for such people, for all you know, they have occult hepatitis B infection. That's why they are not responding to the vaccine. Because your surface antigen can be negative, but you still have a B. So those people, will let them go and do a viral load and we'll do a profile for them and look for the presence of the core antibodies. So that's, and then if that is still normal, then we may have to do genotype and look at which strain and look for any possible strains of Hep B that they may have that for which is preventing them from responding to the vaccine. And of course, if you're a health worker and you're exposed to a patient with a patient's body fluids or contaminated blood, what do you do? Just like HIV, we have post-exposure prophylaxis for hepatitis. Okay. And within this period, of course, it will be counseled not to donate blood or blood products, organ tissue. Of course, it can be in semen and everything. So you have to wait. But you see, the good thing is if you are exposed as a healthcare worker, and this is strictly for occupational exposure, healthcare workers, my focus is on you. If you're exposed and you have been vaccinated and your titers are more than 10, you realize that there's no intervention necessary. That means that you don't even have to worry whether the patient that you were exposed to has hepatitis B or not. No intervention is required. That's why it's good for everybody who works in a health facility to go and check. If you've taken the vaccine, go and check your titers to be sure that you've produced enough surface antibodies to protect you and provide that kind of passive immunity for you. Now, if you've taken the vaccine, you've completed your vaccine all right, but your titers are less than 10, then that one, we need to know the patient's hepatitis B status. If they are negative, all we have to do is give you another dose of the vaccine and immunoglobulin. The vaccine without the immunoglobulin, and you'll be fine. You repeat your titers after 2 months to check if you are there. But if the patient's status is unknown or the patient has hepatitis B, then we have to treat you like we treat the babies. We give you the hepatitis B immunoglobulin and give you the vaccine in addition. And it's the same for whether or not you've been vaccinated. And you don't want to be taking that and be lying down and be worried that, hey, what if I've seroconverted and you're worried? So just go and take the vaccine and protect yourself. Then lastly, we'll look at factors that accelerate progression. And of course, it's been shown that even obesity and concomitant fatty liver disease, so those with metabolic dysfunction associated fatty liver disease, or even previously what we termed as non-alcoholic fatty liver disease, when you're obese, when you take a lot of alcohol, your antigen status, your viral load, all these things can accelerate your progression. In fact, they found hepatitis B DNA, the viruses or viral load in patients in the sera of alcoholics who have liver disease and they don't even have hepatitis B. Can you imagine? the surface antigen was negative, but you're a chronic alcoholic, and they did a viral load, and they found traces of the viruses in your serum just by being alcoholic. And so if you have a beer, you drink alcohol, it's like you are accelerating your progression to liver cirrhosis and liver cancer. And the only thing that has actually been shown to slow down the progression is coffee. And I don't know when that research was done or whether it's being reproduced elsewhere, but actually coffee is the only thing that has been shown to sort of like slow down the progression to hepatocellular carcinoma if you have chronic Hep B. Okay, so I'd like to end, and the summary is that chronic hepatitis B is still a huge public health burden, especially in the northern parts. And as you are well aware, our prevalence is still well above it, putting us in an endemic country. And most of the time, when someone has chronic Hep B, clinically, they will be asymptomatic. And most of the time, when they are coming in, either they are coming in with decompensated cirrhosis or hepatocellular carcinoma or a reactivation, that they're having an acute flare when they are chronic Hep B. The natural cause is usually an interplay between the host immune system and the viral replication. And with the treatment, one, you only treat those who are chronic and you only treat active disease. What do I mean by active disease? Look at the ALT, look at the viral load, and assess for liver inflammation by using your non-invasive method like the APRI score. And of course, tenofovir disoproxil fumarate is available and has a higher barrier to resistance and can be used in pregnancy. It comes in 300 milligram tablets, and the tenofovir alafenamide comes in 25 milligram tablets. So please don't hesitate to put your patients on it. Now, in the past, we're still treating all co-infections, but the new thing with this co-infection is that they've added diabetes and metabolic dysfunction associated chronic fatty liver diseases to it. So that's a new thing that they've added. So if you have a patient who has diabetes type 2, and I mean type 2 DM or non-alcoholic fatty liver disease, and they have chronic Hep B, now you are required to treat them because it's been shown that diabetes accelerates chronic liver disease. And of course, we cannot talk about it without talking about prevention. We would rather you don't get it at all, but when you get it, we'll treat you. Of course, so prevention, get your vaccine, check your titers. If you are fine, then you don't need to be worried when you are exposed to contaminated body fluids or blood. And of course, if you are not sure what to do, talk to a specialist or talk to a doctor, refer to a facility that have the capacity to be able to evaluate the patient adequately and treat. You don't have to keep a patient, you are not sure. And I saw a pregnant woman the last time at clinic, and she had delivered. She had just delivered. And no, she had delivered for about a year, and she was on tenofovir. And I was worried. And I was like, who started her on tenofovir? Because there was nothing. When I evaluated her, nothing that meant that she should be on tenofovir. Everything was fine. So then I was asking myself, is it that the tenofovir is what is leading to maybe she's getting a good response? That's why everything was fine for me. I went back, I traced the details back to her old labs, and even at the time the treatment was started, everything was fine. ALT was fine, everything. So I'm like, who started you on tenofovir? You understand? And she's a nurse, and health workers, we are very stubborn. So when you are in a chronic inactive state and you don't need treatments, let sleeping dogs lie. Don't go and take tenofovir and make things worse for yourself. And with that, thank you very much and for your audience. Presentation was the resources were largely from the WHO Clinical Practice Guidelines 2024, March last year, and the ESA guidelines that the European Association for the Study of Liver Diseases 2017, and also other few places where I picked a few sources from. Thank you for listening. I don't know if there's time, maybe I'll ask Dr. Katiba if it will be possible to quickly go through the cases, but I'm also more than happy to take your questions if we are unable to go through the cases. Thank you.
Great. Thank you so much. This has been legendary, and I'm sure definitely our participants would agree with me that when I began it all by saying that we are in for a really good presentation, this is what I meant, and we've seen it. Quite extensive, quite straight to the point, and with the necessary details. This has been great. Thank you so much, Dr. Atto. We've gone past the 1 hour mark that we usually put in, and so we'll just allow for 3 questions, and then you can do the cases, and we'll call it a day. I think it's captured virtually everything with updates that a lot of people benefit from. So if you have any question, for the sake of time, we'll take only 3. You could kindly electronically put up your hand. I would ask you to unmute, and then you can have a go. Just to make an announcement before those ones come, I see people still sending messages about how to get the recording of this webinar and the PowerPoint presentation. Kindly look in the chat box. I've put those details there, how to access that. We have a YouTube handle that we put those ones there. I'm just going to put it up again for everyone. So if you need a recording of this, you just have to subscribe to that. I've put it in the chat box. Kindly take a look. So if you have any question, yeah, I see 2 questions already. So 3, yeah. So for the 3, it will be Stephen, Jennifer, and Nick. And then we can probably take the cases and then close for the day. We've gone 30 minutes past the hour that we usually advertise for this. And of course, it's for a very good reason. Definitely hepatitis B hyper-endemic in our region. And so we have to pay more attention to it. Stephen, you are first to go. Please ask your question. Or mute and then you can go ahead.
I cannot hear anyone speak. Well, I don't know if the one asking the question is speaking yet, but I can't hear anybody. Am I the only one?
Yeah, I think probably my network went off. And
Oh, okay.
can you hear me now?
Yes, I can hear you.
Okay, yeah. So I think Stephen had put his hand up, and I asked him to unmute himself. I don't know if was he able to do that.
No, we didn't. I didn't hear anything from anybody.
Okay, all right. So let me ask him to unmute again. Stephen, please go ahead with your question.
Okay, thank you very much. That was a very insightful and detailed presentation. Mine has to do with prevention of mother-to-child transmission. When the mother is reactive, we know the baby has to be given the Hep B vaccine and then the immunoglobulin at birth. But in situations where they can't afford both, we have had some data, or we have kind of chance upon some research that indicates that if they take only the vaccine, it could offer them, the baby, some protection. But we ran into a problem with some midwives who didn't agree, and they just want that they must take both the immunoglobulin and then the vaccine. If they can't afford both, then nothing should be done. So I want to confirm from you, if you can't afford both, is it better we take only the vaccine? That is in terms of exposed babies. Thank you.
Thank you very much. I think that's a very good question. Well, all the literature that I reviewed prior to this presentation talks about taking both. And the WHO is quite strong about taking both. And I don't know whether taking just one is not ideal, obviously, because that's not a recommendation. But normally, the babies would even get the hepatitis B vaccine as part of their pentavalent in Ghana per immunization schedule at, I think, 6 weeks, 10, and I think 14. So they will get the pentavalent. So they'll get the diphtheria, pertussis, tetanus, Haemophilus influenza type B, and hepatitis B together. So it's difficult to say that, okay, just take the vaccine and leave the immunoglobulin. The recommendation is I take both. But what I would rather prefer, which I haven't seen anywhere, so this one is, if you can't even do both, I'd rather give you the immunoglobulin. Since the vaccine, you would get it anyway at 6 weeks. But of course, I may have to find out if just taking the vaccination without the immunoglobulin is protective, because I really do not think that it will suffice at birth. So if they cannot afford, it's difficult. It's difficult. But if I have to stick my neck out, I'd rather give them the immunoglobulin, since they will not pay for the vaccination anyway. For the national immunization schedule, the vaccines are not paid for. So, but the recommendation is that you do both. You have to do both. You must do both. So it's important to start sensitizing them very early, conscientizing them during the pregnancy that, please. Then that's what we did for one of our patients. Right from there, when we went to see her, she was almost due. We started sensitizing her. So we even got the money from her, bought the vaccines car and put it down in a cold chain somewhere, waiting just for her to deliver so that she will get it. So that is how I would respond to your question. But it's important they do both rather than just do one. It's ideal they do both.
Yeah, so just to add on to that, I think this same question came up at the gaslit the gaslit presentation on hepatitis B, chronic hepatitis B, and I think Dr. Ejua J, one of the gastroenterologists, gave some insights into that. And like Dr. Atto has mentioned, the ideal thing definitely is to take both the vaccine and the immunoglobulin on the day of birth. But from what, of course, this again is what we usually call expert opinion or guidelines, because we don't have like meta-analysis or even a randomized control trial on any of that. And nobody will even do such on human beings where you really be seeing who would be protected. How about the babies that will get it? So the advice from sort of like what I'll call a third world advice was that on the day of birth, because of our peculiar social-cultural practices, wherein when the baby is born, and if you look at the percentages Dr. Atto put up, the highest percentage for the horizontal transmission was around those from 0 years to 2. And most of it from what Dr. Ejua et al. Picked up was that before the 6 weeks, when they come, they would have already picked that infection from either grandma who had come to birth the baby or any of the close households. And like Dr. Atto mentioned, most of it, once we pick it up in that early life, your chronicity is about 95%, progress to chronicity. So in a statement, what she said was that half a loaf is better than none. And when you are met with such, on such a crossroad, it may be better to err on the side of caution, i.e., woman cannot afford, and you too cannot support her to afford. The system has collapsed and the system cannot support her. Sometimes it's terrible being a Ghanaian when it comes to such things, that your own country cannot support you. They can't support that precious baby with an immunoglobulin for free. And when it gets in there, what her advice was that since the vaccine was cheaper, it's maybe better to give the vaccine on the first day, because woman cannot afford, you cannot afford to get the immunoglobulin. So the vaccine on the first day may suffice. But ideally, best practice is you have both of them. And then, Stephen, I'll be happy if you can share. You mentioned that there was a paper which made the recommendation for the vaccine, the vaccine to be given when there's no immunoglobulin. We'll be happy to learn from it as well, if you can share that with us. But again, when you come to that crossroad, erring on the side of caution, medical ethics, beneficence, non-malfeasance, you err by giving just what is available, which is the vaccine. Because most of the times, 6 weeks by the time they come for the pentavalent, they already picked up the infection. So let's see the second person, Salim, and then the last one is Asana Mustafa. And then we can have the case studies so that we close for the day. So Dr. Salim, please go ahead. I've asked you to unmute yourself.
Hello, good evening, boss. Thanks, Dr. Katiba, for the platform and Dr. Hatto for the insightful presentation. I actually left my question on the chat box, but when boss didn't mention my name, that's why I raised the hand. So my first question is, I'd want to know what's the rationale for using the viral load of 2,000 international units per mil for the general population and 200,000 for pregnant women, when in our setting we know that vertical transmission is the major route for the viral transmission. The second question is, for those pregnant women who have HIV and Hep B co-infection, the recommendation is that when we have comorbidities like that, you treat. Does that hold for pregnant women too, or we still have to be checking for the viral load of 200 international units and more. And I just also want clarity on the fact that those mothers who are Hep C antigen positive, that's just by way of screening during the antenatal, do we just base on that to give the immunoglobulin and the vaccine to the baby, or we have to do and check the envelope antigen and all that before we go ahead to provide the baby with immunoglobulin and vaccine? Thank you.
Thank you very much. I think that's a very brilliant question, to be honest, the first one especially. The second one is pretty straightforward. You don't need to check anything for the baby before you give it. Just by virtue of the exposure to a pregnant woman who is positive, you have to give them the immunoglobulins and a vaccine. You don't need to check any serological study, do any serological studies before. By virtue of the mother being exposed, once the baby is born, give your vaccination and your immunoglobulins. Now, the first question is the rationale for using 2,000 for non-pregnant women and using 200,000 for pregnant women. And it will be difficult to answer that, but I can attempt to answer, and maybe Dr. Katiba can come in. The issue is that you want to, initially, there's still a lot more about hepatitis B that we don't know. Initially, we were only capping our viral load to 20,000 if they are E antigen positive, and 2,000 if they are E antigen negative. And all those things were putting a lot of barriers to treatment. Now, the truth is, why do you want to wait till there are high levels of active viral replication or viral load before you intervene? You see, the whole point is for you to prevent development of cirrhosis and hepatocellular carcinoma. So we don't even want to get to the point where the viruses are replicating in their numbers. Do you understand? So I believe that the WHO took out the need for you to now check E antigen 20,000, E positive 2,000, so that the barriers to treatment can be reduced, so that we catch them early, so that we do not wait for you to come in with 1 million copies or even 50,000 copies before we start treating you. As early as 2,000, we are already treating you, so that at all times the virus is suppressed. I hope it's clear. Now, the rationale for the 200,000 for the pregnant women, the pregnancy itself, it's difficult to use the methods that we are using to assess for pregnant women. That's why in pregnancy, I didn't talk about APRI score, because in pregnancy, by way of physiology, your ALTs will be deranged, especially in the early on, because when you are pregnant, because of the baby, there are extra things. There are a lot of physiological things that go on in pregnancy. So most of the things that can be used to assess pregnancy, we don't use them, except, of course, the viral load. And even for those that require treatment, we wait till after the first trimester. And because the first trimester is when organogenesis, babies have been formed, parts of the baby is being formed and things. So you don't want any interference with the medication. But the pregnancy viral load has always been capped at 200,000. It hasn't changed. And I don't know if maybe later, when there are more studies and there's more evidence to suggest that maybe we need to treat them at a lower viral load, maybe that can happen. But based on the studies that have been done and all the literature that is available, it's remained 200,000 for a very long time, because I probably believe that probably it's only after above that level that active viral replication may cause significant harm to the baby. Then I think there was a part of your question where you talked about co-infection. Where if they have Hep B or Hep C co-infection, whether you still go ahead and treat, or you'd wait for the viral load. Once they are pregnant, they are pregnant. So the recommendation is that unless your viral load is more than 200,000. The only challenge with that is that the hepatitis C can be cured. So the hepatitis C also has to be cured. But even with that, when we want to treat the hepatitis C in pregnant women, we still wait for them to go beyond the first trimester, just like we do for the B, because that can also be problematic, especially because of the medications. But if you are going to treat the C, this is what makes it tricky. If you are going to treat the C, because the C can cause a reactivation of the B, then it would mean that you treat the B. So it's not a straightforward thing. And I would wish that if you have such a complicated case like that, at least you involve, depending on where you work, you involve your specialists and the physician specialists and the ONG, because once you are pregnant, you are pregnant. For pregnant people, the only thing that matters is their E antigen status and their viral load, which has to be more than 200.
Great.
Thank you. Over.
Fantastic. So I think there was someone whose hand was up, but the person has lowered the hand. So let's go ahead and do the case studies.
Okay, all right. So I tried to answer some of the questions too in the chat box, but the typing has become problematic. So maybe I'll just take one or two with your permission, please.
Fantastic.
Somebody wanted to know why people with chronic inactive Hep B may be described as being medically unfit when they go for medicals in the security services or they are denied visas to certain countries. The truth is, nobody should deny you a visa because you have chronic Hep B. Of course, if you have any infectious illnesses, you are supposed to declare, and there's a form, usually all these international documents that you fill. But countries reserve the right to admit people into their land or their borders, and they may have their own rules, but they cannot use your illness to discriminate. As to why you may be described as being medically unfit for security services, I'm not sure, but it may be when they saw your labs, they saw some biochemical abnormalities or you had some serological abnormalities, and based on their own protocols, they may think that that may not be appropriate for them. But I don't think you can be denied entry into the security solely based on the fact that you have hepatitis B. I don't know what the recruitment protocols for them are, so I really cannot comment. And you want the treatment to be made less expensive. That's true. The only way we can do that is if we liaise with the national health so that the treatment is put on insurance. And if you do that, then that can be made less expensive. Then someone is asking if tenofovir can be taken for more than 6 months. Yes, it can. Like I said, the therapy is lifelong. So most people are actually on it for a very long time, unless you meet those very specific indications for which you can do the tenofovir, you can stop your medications. Otherwise, you continue. And the significance of the E antibody in the profile. So that means that if your E antibody is positive, then it means that you seroconverted. And that's basically what it means. And that may be useful if we are deciding to stop your nucleoside analogs. Other than that, it doesn't really play much role. Because if you look at the indications where you can stop therapy, especially for those who were E antigen positive, if they get a functional loss of their E antigen and they seroconvert, is one of the indications. And you've done a consolidated therapy for 12 months, that's a year, and you can monitor them. It's one of the things. So if they seroconvert and other things are there and you want to stop it, at that point, it has some significance. Otherwise, if it comes to purely making treatment decisions based on the current guidelines, it doesn't really have much role. And for those with Hep C antibody positive, but no RNA detected, later becoming RNA positive, is there the need to continue monitoring? Is there a room for a patient with Hep C antibody positive? Is there a room for a patient with Hep C antibody positive, but no RNA detected, later becoming RNA positive? Is there the need to continue monitoring if Hep C RNA is negative? So if your Hep C antibody is positive, it practically means that you may have been exposed or you have an active infection. But if there's no RNA detected, it tells us that maybe you don't have an active infection. It's just an old infection. If later your RNA becomes detected, then of course it's a few things. There's a concept of window period with hepatitis B. I don't know if it applies with the C, but I would think that if your RNA was not detected and later you become positive, I'll interpret your Hep C antibody being positive to mean that that was a previous exposure, and maybe now you do actually now have an active disease. And for that matter, yes, if you have a B as well, the Hep C together with the Hep B would have to be treated. And of course, I think monitoring would also be relevant. And if you have a chronic Hep B patient, inactive carrier who is not on treatment, who gets exposed, what do they do? How about a chronic Hep B patient, inactive carrier, not on treatment? then get exposed. What do they do? So exposed, when you say exposed, you mean that they get exposed to another virus. If they get exposed to the B virus again, they're already infected. They may be chronic inactive carrier, but they still have the infection. So that means that their surface antigen will still be positive and their core antibody, the core antibody will still be positive. So really, there's not much to do. There's not much to do. Okay, so quickly, I'll go to the case because we have really run out of time. Maybe we'll do just two of it. Sorry for prolonging this presentation, but I think hepatitis B is always like this. A lot of people have questions. So the first case, a 35-year-old, we saw at the ER with nausea, vomiting, and lethargy. She has a past medical history that was significant for type 2 diabetes with poorly controlled sugars and also known to have chronic hepatitis B. Other findings were unremarkable. Clinical exam revealed an acutely ill woman, icteric with moderate pallor. Liver function test was unremarkable. Ultrasound showed chronic liver parenchyma disease, and APRI score was 1.8. Ritual screening hepatitis C was not reactive. Would you treat or not treat? You can just put it in the chat box, or you can just tell me quickly. Okay, so Sani said, no. Oh, no, this is a question. Or you cheat. Okay, you cheat. Okay, so yes, I agree with you. So if you look at the current guidelines, now this patient has chronic Hep B and she has type 2 DM. So of course, we have to treat her. And even if another reason why we would also treat her is you look at the APRI score. The APRI score is 1.8. That means that she already has liver cirrhosis. Okay, so you have to treat her. Okay. And like I said, in the past, we only treated cirrhosis. Now we are even treating significant fibrosis. That's F2. F2 means your APRI score is at least 0.5. And this is a 28-year-old woman, 34 weeks pregnant. We were called to see, and these are all real life cases we've managed here. She were called to see because of surface antigen positive. This is her profile. She had the antibody to the core antigen. LFT show ALT of 67. AST was 55. Other parameters were unremarkable. Ultrasound wasn't done. Viral load requested, not done, and they said they couldn't afford. Would you treat or not treat? And is there any advice or counseling you give her, and what would it entail? Let me see if somebody has put anything there. Okay, there's nothing here, but this is somebody that ALT is 67. But like I said, in pregnant women, we don't use ALT, so the APRI score and things do not really matter. And what you only need is a viral load, which is 200,000, and e antigen positivity. She has e antigen positive. She cannot do viral load. You can safely treat this woman. And what's advice? And also, she's beyond the first trimester. So you can safely treat this woman if you are pushed to it. Otherwise, if she can get the money to do the viral load, you wait and do the viral load. What advice or counseling will you give her, and what would it entail? You have to make sure the baby gets the immunoglobulins and the vaccine at birth. And you also have to counsel her that even after delivery, once the baby is out, up to the period where she's done breastfeeding, now she also has to come in to be assessed on her own merits, whether she deserves to be treated or not. So once they give birth and the baby is born, up to the time they are done with breastfeeding and all that, or up until the time the baby takes all the immunization schedule, the women also have to come in to be evaluated independently to determine if they also require further treatment, okay? Whether you continue the tenofovir or not. We won't take everything. Maybe we'll take this last one. Then a 45-year-old referred to see the specialist. This is a case that I saw just yesterday, and he is known to abuse alcohol. He drinks to stupor. Before he came to see me, I'd been started on tenofovir 300 milligram a day. A week prior to coming to see me, he was very cachectic, moderately pale with a tinge of jaundice. He had hepatomegaly, moderate ascites, sensorium was intact. AFPs were 17, ultrasound features of ACC, LFTs were deranged. Would you continue his treatment or not? And this one, of course, somebody has already developed hepatocellular carcinoma, so there's no need to continue the treatment. The treatment will have to be stopped, okay? Because that's the whole point of the treatment, to prevent this from happening. If it's already happened, we have to stop the treatment. It's counterproductive. The only time you still do the treatment in the presence of a complication is if they have cirrhosis. Cirrhosis, whether it's compensated or decompensated, you can treat, but not if they've already developed hepatocellular carcinoma. So the MO started tenofovir, but the man has already developed HCC, so I had to stop it. Okay, so with that, I think I'll end the case studies here. I may not be able to take everything. I'm really sorry if I couldn't take your question. The the time is fast spent. If Dr. Katiba is kind to us, maybe we can take one or two more. Otherwise, I'm handing over to Dr. Katiba. Over.
Great. Thank you so much. This has been good. I think we've done 2 hours of hepatitis B presentation. We have uploaded on our YouTube channel a hepatitis B presentation as well. These two answer most of the questions that were asked, as well as those that were put in the chat box. Like Dr. Atto had done, answering those questions in the chat box. I've also done same as he was talking. All those that were left unanswered, I've answered those as well. So I think we are good to go. We are deeply sorry that today we've done 2 hours, but I think it's for a good reason. And so we join me in thanking Dr. Atto for an excellent presentation. This has been insightful. This has been legendary. This has helped us to understand the hepatitis B in detail. And like I mentioned, this will be put up on our YouTube channel. I've dropped the link in the chat box. You can check and click on it and subscribe so that at any time you would want to relook at this, revisit this, you can have that done. Next week, we'll have another legendary presentation as well. Kindly like us on Facebook and LinkedIn, Ghana Medical Help. You have the details of that presentation. However, if you are not a social media person, don't worry. The same link you used to join this presentation today is the same link we've been using for 3 years now. The link never changes. So if you remember on a Thursday, just click on that link and you are at the right place. Same on Fridays, we do maternity-related presentations. The women are very precious. Pregnant women are precious. So we've dedicated Friday webinars to them. So we talk topics regards obstetrics. So you can encourage your midwives, if they have the time on Friday, same time, 3 p.m. Ghana time. Ghana time not meaning after 3, at exactly 3 o'clock we start. 3 to 4, mostly an hour, we're able to. Sometimes we go a little beyond, like today, especially when it has to be a very common topic. So we are grateful to Dr. Atto for a legendary presentation. You are a great guy. We have the men. Dr. Atto is with us at the Upper West Regional Hospital. If you need him, he's available. Clinic is on Tuesdays, and then there are intermediate services as well. You can visit him and you have your medical issues regards to hepatitis B and the like all sorted out. So thank you so much. We are grateful for the time that you've made to join us today. See you again next week, Thursday and Friday. Tomorrow we'll not have the maternity-related webinar because we are doing an emergency obstetric and newborn care training program, 3-day training program at the Upper East Regional Hospital. So we have changed locals from Upper West to the Upper East. And so because of that, our faculty is more engaged in that training program. However, next week will be available. We'll have the Thursday presentation, 3 to 4. We'll have the Friday presentation, 3 p.m. to 4 p.m. Thank you so much for joining us. Dr. Atto, we are grateful. God bless you.
Thank you very much for having me. God bless you too.
All right. Bye-bye.